mature leukemias and lymphomas. We talked about melanocytic, now we're getting into melanocytic, and chapter 28. Okay? We've been talking about the content of chapter 28 the last time we did. I'm going to finish up this particular chapter. Okay, it goes to further heading mature lymphocytic types of neoplasms. Now, starting on page, do you have any questions about that? None? You good? Okay. Starting on page 546. Plasma cell neoplasms. Not to be confused with B cells. Okay, there are B cell neoplasms, there are T cell neoplasms, but these couple of pages deal strictly with plasma cell neoplasms. You know the primary responsibility of plasma cells is to produce immunoglobulins, correct? Okay. When B cells mature, they go to a plasmablast, and then a proplasmacyte, and then to mature plasmacyte. So these types of neoplasms, these types of lymphomas involve just the plasma cell population, which is one point I wanted to make. Now, what do these, well, number one, realize that they produce immunoglobulins. So when you have an abnormal clone proliferation, malignant proliferation, cancerous proliferation of plasma cells, they don't produce normal functioning immunoglobulins. What they provide is not functional immunoglobulins, right? And one of our jobs is to help the physician distinguish if there are a lot of immunoglobulins presented in the patient's plasma, is distinguish those immunoglobulins as being functional or non-functional. If they're not functional, and there's an overproliferation, and we find some in the blood plasma, then we know we're probably looking at a plasmacytic neoplasm. Now, the unique thing about this is that, I'm going to give you a couple of characteristics, is plasma cell neoplasms do not involve the lymph nodes. So people are going to present with the rubbery, swollen lymphoadenopathies that we see in many of these other situations, okay? And then, of course, the abnormal, not functional immunoglobulins that these clones of malignant plasma cells produce are it's a clone of plasma cells, so they produce a single, very narrow type of abnormal, non-functional immunoglobulin. Now, how do we realize that? How do we pick it up? By electrophoresis. And your book gives you a good illustration on page 547, showing you an abnormal electrophoretic pattern demonstrating what we refer to as an M spike. You can think of that as being monoclonal, you can think of it as being, sometimes we call it the church spike because it looks like a church steeple, but it usually represents just a very narrow, very abrupt, very obvious M spike. So electrophoretically, guys, you know what a normal pattern looks like, right? You have albumin, alpha-1, alpha-2 beta, and then the gamma area is usually, I'm exaggerating, the gamma area is usually a wide presentation representing all immunoglobulins, okay? But with a plasma cell neoplasia, you'll have a very narrow spike to the detriment of the other immunoglobulins, all right? And that should be pretty obvious given that diagram. Now, there's a difference between, and categorizing these, between an early neoplasm and a myeloma. A myeloma will show you an M spike of greater than 30% of this area under the curve, okay? And by the way, when we take a membrane such that we've electrophoresed immunoglobulins, then we run it through a densitometer. A densitometer is much like a spectrophotometer, but it measures the density and gives you this type of a tracing, okay? So if this area is greater than 30% of the total area under the gamma area, then we're looking at a true myeloma, not just a neoplasm, just not a few plasma cells that's gone awry, right? So myelomas, plasma cell myelomas represent an M spike that's often, extremely exaggerated, again, as I said, about 30% or 30 grams per deciliter. You might see in some, and that's what I was looking for, I have patterns someplace I wanted to show you. If this is not 30%, maybe it's only a little, then you're probably looking at a neoplasm, not a true myeloma, okay? Now, myelomas, actually the neoplasms, can be categorized in accordance with the type of immunoglobulin that the abnormal clonal proliferation of the plasma cell produces. Is the immunoglobulin an IgG, an IgM, an IgA, an IgD, an IgE? Or is it just kappa light chains or gamma light chains? There was a lot of research done, and a physician by the name of Dr. Vince Jones, realized that he could have and did have some cases of plasma cell myelomas that had a normal electrophoretic pattern, like this, that I drew on the board. But the patient was presenting with all the signs and symptoms of a myeloma. So he did a urine electrophoresis. Of course, you have to concentrate the urine first. But what demonstrated, and by the way, do you know what a normal urine electrophoresis looks like as opposed to a plasma electrophoresis? I should say serum. This is serum. Should find no proteins in urine, right? We've talked about that in body fluid. There should be no proteins in urine. That's why the dipstick should be negative. So typically with urine you have a flat line, maybe a little bit of a hump here or there. And if there's a little bit of albumin, maybe a little bit of albumin. But essentially urine electrophoretic pattern should be straight line. If we have a Bench-Jones myeloma, okay, then you're going to see spikes in the gamma area that represent only the light chains, okay? Might be a little bit, so it could be kappa or it could be lambda. Okay. The reason is because of the molecular weight. Kappa chains, lambda chains are very, very light in molecular weight. They can very readily pass through the basement membrane, okay, from plasma to urine. And if they do have a myeloma of light chain type, then the plasma electrophoretic tracing is going to be normal, but the urine electrophoretic tracing is going to have a little bit of a spike in the M area, again representing either, can't be both, has to be one or the other, either kappa type or lambda type, right? That's called a Bench-Jones myeloma. In that spiral-bound booklet that you have, representing protein electrophoresis and all the combinations thereof, go through that. You should see some patterns that strictly allude to various types of abnormal proteins found in urine. Okay? You need to kind of look at that as well. So we have this depending on the M spike, one of the criteria used is how much, okay? And then following is using 30% or 30 grams per deciliter, I should say, is the cutoff. Just dividing tragic myeloma from that's the wrong term, a plasma cell neoplasm. You don't want these, by the way, okay? How we don't know yet the composition of that M spike. We don't know if it's an IgM heavy chain or an IgD heavy chain or an IgE heavy chain. So what we do in the laboratory to identify the composition of this M spike is an immunofixation. Have you guys talked about this at all in immunology? We used to do an immunoelectrophoresis. Difficult to interpret, horribly difficult to interpret. So that technology has been dropped, and now in its place, we do an immunoelectrophoresis, going to an immunofixation. Looking at this case on 547, page 547, the third illustration there represents an immunofixation. Okay? It's pretty easy to read. It's an agar-type material, okay, to which then are cut various troughs. Okay? And if you look at this, we run an antibody against certain proteins. The column that's labeled SPEC is an all-encompassing control material. Has all types of immunoglobulin antibodies in it. But if you look at the next one in, you see it says IgG, followed by IgA, IgM, kappa, and lambda, right? And so we electrophoresis first, then we add antibody, and the antibody will link up obviously with the immunoglobulin, whether it's via a heavy chain or a light chain, and then you get this intense precipitation in terms of a band. So they're pretty easy to read. And given this M spike that's shown just electrophoretically in the above illustration, we can decipher what type of M spike this represents by looking at this immunofixation. And this is easy to read. It's an IgG kappa type. Can you see that? We have a heavy band in the IgG area, okay? And then moving across in the identical location, when it says kappa, you can see a heavy band. So those mu heavy chains are paired with kappa light chains, so that I have an IgG kappa type myeloma. A little bit easier to read, right? So I do have some of these that I can't, I'll look for them again to see if I can find them, so I can have them for you tomorrow. Yeah, let's get together tomorrow. Why not? Okay. Other signs and symptoms of a plasma cell myeloma. And your book does a great, your author does a great job describing this, and that's the acronym CRAB. C-R-A-B. Okay. So if the patient fits and can be defined and fulfills this CRAB acronym, plus with bone marrow involvement, where plasma cells reside, okay, and culminating with an electrophoresis, plus an immunofixation, it's easy to diagnose, okay? What does CRAB stand for? Okay. Read the book. Hypercalcemia, elevated calcium, okay. Extremely elevated calcium, hypercalcemia. Kidney involvement or renal involvement, meaning renal insufficiency. Okay. Thirdly, the A stands for anemia, and then the B stands for bone marrow involvement. Okay. Bone lesions or lytic bone. Many of these cases I'm talking about bone involvement. Many of these cases, when you have the overwhelming proliferation of a clone of plasma cells, of course in bone marrow, then that's to the detriment of bony tissue. If you look at, you turn the page and look at 2810A, when they take an X-ray, this is what the skull will look like. Other bones will show these lytic lesions as well. Looks like somebody could take their thumb and punch a hole through the bony structure, and you see all of these, particularly around the peripheral of the skull, all of these punched out holes. That's what because of the lytic bone lesion created by the overgrowth of malignant clone plasma cells. That's why, too, you have a hypercalcemia. Okay, the calcium from the bone, lytic bone lesions are leaking out in the peripheral blood. So we have a hypercalcemia, we have these lytic bone processes that are apparent on X-ray, and then two, in worst case scenarios, kidneys shut down, kidney involvement, and that kind of thing, all right? So, going back to page 547, if you look at the table 28.4, primary cell neoplasms, this is the categories. And remember, parallel that, clone proliferation, abnormal growth of types of plasma cells, parallel that with functional hypogammaglobulinemia, why these non-functional immunoglobulins are just overwhelming the true functional immunoglobulins that can serve as antibodies and do other things. So it's a plasma cell neoplasm with functional is a key word, hypogammaglobulin anemia, okay? Now, plasma cell myelomas, okay? Plasma cell myelomas typically will present with very, very narrow church spikes or M spikes electrophoretically. That can also be present in urine if there's release of kappa and the light chains, okay? Maybe symptomatic, maybe asymptomatic, and eventually, of course, it will go to a symptomatic situation, okay? Symptomatic means there's generally diffuse bone marrow involvement and the patient has met the criteria or that acronym, i.e. CRAB. Now, it can be just osteolytic, meaning in early stages just the bone is being attacked. Okay? Now, again, let me go back. What separates symptomatic from asymptomatic is the concentration of these immunoglobulin in blood plasma, using 30 grams per deciliter as a threshold. Okay? So symptomatically, as a primary neoplasm or myeloma, typically we have to have an M spike demonstrating protein, abnormal protein greater than 30%. Less than 30% would go to an asymptomatic situation. Not only do we use these laboratory tools to help delineate these subcategories of plasma neoplasm, we also have and can use FISH, F-I-S-H, which isn't described here, and we're going to talk about this next week. FISH is fluorescent in situ hybridization. Fluorescent, so we use fluorescent dyes. In situ hybridization, and that's all I'm going to say right now. We use it here, we use it to identify in cytogenetics, we use it to identify Philadelphia chromosomes, chromosomal translocations. We use FISH for a number of things, not just in this case. Okay. Now, one other point I want to make, given that these myelomas can and do produce a single immunoglobulin, which cases and what immunoglobulins are demonstrated more commonly. Well, there's a sequence. We see myelomas as being mostly of IgG type. Following that is IgA. Following IgA is IgM. And to tell you the truth, I've never seen an IgD or an IgE, rather, an IgD or an IgE. I've seen definitely IgGs. I've seen IgAs and I've seen IgMs in that order in terms of frequency of presentation. All right? So remind me to talk to you guys about fish. In fact, turning the page again, I'm looking at 584, there's 548, I translocated the 48. 548, you can see a substantive chart that talks about these neoplasms that I just described. Symptomatic myeloma, yes. M spikes, yes. Clonal proliferation of plasma cells, yes. Where? In bone marrow, to the detriment of all the other immunoglobulins. Meets the criteria of CRAB, and then the M spike has to be again greater than about 30%. Asymptomatic, M spike, yes, but no other organs are involved, and you can read the rest of this. Okay, monoclonal gammopathy of undetermined origin, or I should say undetermined significance. They do present similarly, but again, the immunoglobulin concentration is less than 30 grams per GL. Now, moving on then. There's some special tumor cells that are recognizable in lymph nodes. We typically don't identify or see lymph node biopsies, but that doesn't mean we're going to not ask you this material on the boards. So these are kind of special tumor cells that go to, if you would, T cells. So what we've been talking about up to this point are B cells and plasma. Now I want you to switch your thinking and think about T cell myelomas, T cell neoplasms, all right? And that should finish up the chapter. T cells. There's a variety, and some of these involve skin lesions. Okay, I want you to keep that in mind. T cells. Why? Because T cells not only are the most popular lymphocyte in the circulatory system, but they also populate just under the skin. All right. So there are a number of T cells. Let me see, did I skip something that I wanted to point out? Yes, I did. Before I get there, let's finish up again. I want to go back to plasma cell, neoplasms. Look at figure 2811 in your textbook. In lymph nodes, again, these go to specialized tumor cells that kind of point to a plasma cell dysplasia. There are cells called Dutcher cells, number 1, okay. Flame cells, number 2, and Mott cells, number 3, okay. So Dutcher, Flame, and Mott, M-O-T-T. And these illustrations kind of allude to those and give you an idea of those 3 cells. Now, what are Dutcher cells? Dutcher cells are just plasma cells that contain an overwhelming, in the cytoplasm, okay, immunoglobulins, the non-functional immunoglobulins. And one of the reasons I want to raise this point, because I was working with a medical resident at one point, and she took her boards in pathology, and she came back and she said, there were these odd-looking cells, and I had no idea what they were. So she described them, and I said, oh, you're talking about a Mott cell. She said, a what? So even at that level, this was a confusing situation for a pathology resident. It does go to plasma cell myelomas. Now, a Dutcher cell, if you read the definition, it's obvious. It's a plasma cell that contains intranuclear precipitates of immunoglobulins. And the Dutcher cell, that's illustration A, figure 2811, illustration A goes to a Dutcher cell. And there's a long arrow in the illustration pointing to a Dutcher cell. So there's a single inclusion in the nucleus that's just an overwhelming blob, if you would, of immunoglobulins. Okay. So we have an abnormal tumor cell, abnormal plasma cell, again, with this blob of immunoglobulins in the nuclear structure of the cell itself. Okay. Looking at illustration B, I've seen these once. Flame cells. Okay? It too is an abnormal plasma cell. Again, they're usually not found in the peripheral blood, they're found in lymph nodes. It's overwhelmingly, contains an overwhelming volume of non-functional immunoglobulins, but then when we stain them, they stain red. That's why they're called flame cells. They have a red tinge to the cytoplasm. And particularly around the periphery of the cell itself. These aren't as red as what I've seen. Maybe it goes to staining and photography. But they're called flame cells because, again, they're just overwhelmingly laden with non-functional immunoglobulins. And then the Mott cell, which is shown to you in figure C. Sometimes we call those grape cells because they look like just a bunch of grapes of immunoglobulins, non-functional, that have precipitated out in the cytoplasm. So there's multiple globules of these inclusive types of immunoglobulins. So to me, it does look like a grape cell, but it's called a Mott cell. Okay? Lots of inclusions. Now, like I said, these are unique cells that we find, particularly in the lymph nodes and possibly the bone marrow. So you're not going to see these, but this is the correlation. What we will see on the peripheral side is Rouleau. Okay, not pseudo-Rouleau, real Rouleau. So when you do the saline replacement test, the Rouleau's not going to go away. Okay, it's going to stick around. And if you look at illustration D, obviously that's Rouleau. So we see Rouleau on the differential, and what the pathologist will see are these Mott cells and flame cells and Dutcher cells. Okay? So correlating that cellular morphology, that's what we see on the differential. With that being true Rouleau, then they can make the diagnosis of plasma cell myelomas. Now, one hint, okay, and this is an important hint. Take a look at that illustration. The background is blue. This could be a good board's question. If you only had cells to look at on the differential that represented Rouleau, is there one perhaps unique finding that will allow you to distinguish true Rouleau from pseudo-Rouleau? And that's if you look at the background, you look at the smear, you look at the background, it's going to be bluish, okay? It's going to be a dull blue, a dull gray, okay? With Rouleau, red blood cells, that usually means it's true Rouleau, okay? So this bluish background, always look for this bluish background, all right? What is it? Again, plasma cells, overproliferation, producing a lot of non-functional immunoglobulin. Again, it's immunoglobulins that have been not quite precipitated, but the blood is viscous, thick, because of the immunoglobulins being produced. And when you make the smear, by the way, it's pretty difficult to make the smear. But then when you stain it, it's always going to have this bluish background. All right? Now, let's talk about T cells. And this is the last few. And I kind of like this chapter. I don't know why, I have a liking for the plasma cell neoplasms. Don't ask me why. Okay, T cells. Okay, T cells, T cells, you know what they are, you know where they go up. These are mature T cell neoplasms. So when we do the immunophenotyping, the CD markers will represent mature T cells, okay? Mature T cell markers, CD markers are the low numbers. Mature B cell markers are the higher numbers, okay? So these are CD2, CD3, CD4, positive representing T cells, and so on. All right. Now your book does introduce you generically to T cell neoplasm. So read that paragraph. I don't have a lot of time, so I'm going to skip to Sézary syndrome, which is at the bottom of the page. Okay. Sézary, T cell, T cell neoplasm. One of your jobs is to recognize Sézary cells in the peripheral smear. Keep in mind they're T. Probably should show you some illustrations. Sézary cells, remember what the nucleus of a monocyte looks like? There are a lot of creases. So when you find a monocyte, a normal monocyte, it won't lobulate, but it'll crease, and you can see chromatin that represents a crease here and there. Sézary cells, though these are not monocytes, they're T cells, they're plasma cells, they're lymphocytes. We'll also have those creases in the nucleus to the point where they look like, some of them will look like a brain, okay? Some of them will look like, with some creases and indentations. They call it the cerebroform, representing a brain-like presentation of the nucleus. So don't miss these because you've separated B from T, myelomas. So we're looking at T cells here. Other signs and symptoms, red skin, lymph nodes are involved, peripheral blood is involved. Problem is this. There's related lymphoma called mycosis fungoides. That's a wrong name, but it was first thought just to be a skin disease, thereby the name mycosis fungoides. It is not. It's a T cell neoplastic situation such that these abnormal T cells are finding their way and migrating through the skin to the surface of the skin. So Sézary syndrome does relate to mitosis fungoides, but they are different. They're different in their clinical presentation. Okay, they're different in their signs and symptomologies. Sézary cells you have to count. Distinguish the number of Sézary lymphocytes from the remainder of the other cells on the differential, right? It's an absolute count. And the book does give you, this author does give you a kind of a threshold. Sézary cells in the mature Ts. Sézary cells, okay, absolute count has to be greater than 1,000 cells per millimeter cubed. Okay, that's in the textbook. Now, these are T cells again, so they're going to have immunophenotyping, they're going to have the numbers in terms of CD markers. So Sézary syndrome, as I said, closely related to mycosis fungoides as a neoplastic situation, but the presentation is different mycosis fungoides, as I said, was originally thought just to be a simple skin disease. And so people do present with kind of a scaly type of skin, and that's because of these abnormal T cells that are finding their way to the surface. Your book gives you an illustration of a Sézary cell. I don't think it's a good illustration. And that's figure 2812 at the bottom of the page. I don't like it. I have better ones. And if you can look at the nucleus, there really aren't some true forms there, true creases. There's some dense chromatin, but there isn't a lot of creases. So, what do we find? Just to summarize, you have an absolute elevated Sézary cell count. Okay, their CD markers should represent T cells, CD3, CD4, CD2, so on and so forth. They should demonstrate if it's a true mycosis fungoides with red skin, with adenopathies, meaning swollen lymph nodes. Right? The nucleus in these cells, again, are very, very, very irregular, convoluted, and creased. All right, I'm going to probably project some Sézary cells next week so you can get an idea of what they really look like. That's not good. Or you can go to just in a search box, type in Sézary cells, go to image, and then you'll see a bunch of Sézary cells on the screen. Okay, the last group of T cell neoplasms that I would mention are Hodgkin's and non-Hodgkin's. Okay. Hodgkin's lymphoma, so we're looking at abnormal tumor growth where? Lymph nodes. Okay. Not often do we find abnormal tumor cells in the peripheral circulation that would allow us to think Hodgkin's and non-Hodgkin's lymphoma. Okay. So large tumor cells that I want to describe that we see in what pathologists would see in lymph node biopsies and so on. Now there's a few types of subcategorized types of lymphomas that the WHO has recognized. If you look at page 28.6 or table 28.6, you can see those listed. LP is lymphocytic, NS is nodular, MC is mixed cellular, LR is lymphocytic rich, and LD is lymphocytic dilute, and the P is community there. I'm just going to point out a few things. Okay. One, because we don't deal with it. It's mainly the docs and the pathologists involved, because they're looking at lymph node biopsies for the most part. A couple of things they look for, and they're mentioned in this column. The sclerotic presentation or fibrinous presentation of the node itself, right? And the number of lymphocytes, tumor lymphocytes that they see on the lymph nodes themselves. So lymphocytes and tumor cells. So they look at those three things. They look at how fibrotic the lymph node is, and that goes to sclerosis in this table. They look for abnormal lymphocytes, and they compare that number to the number of actual tumor cells. Tumor cells are considered very rare. The one I'm going to talk just a little bit about all of these, but the one I want to strategically point out is LP. Okay? LP is the lymphocytic prominent Hodgkin's. And if you read across the characteristics of LP, you see that the lymph nodes aren't fibrinous at all. Okay, not a lot of fibrin there. Heavily populated with abnormal lymphocytes, which I'm going to come back to. Very few actual tumor cells. But this is what you need. The immunophenotyping by flow cytometry, given these abnormal lymphocytes, represents the side of the CD markers we would typically see on B cells, not T cells. So if you look at that very last column in this table, what does it say? Cell type B. Why? Because the markers are CD20, okay, and CD45, those upper level, higher number markers that represent B cells. So is it a T cell or is it a B cell? A lot of research still going on. But the immunophenotyping by flow is pointing to these may actually be B cells and not T cells. Okay? So I wanted to make that distinction. Now, the nodular NS, as in the name, sclerosis or sclerotic, yes. So fibrin, lots of fibrin tissue is present in the neoplasm, in the lymph node biopsies. The other thing I want to mention is if you look under variants, it says lacunar type cell. I'm going to come back to that. Okay? That's probably, given this table, the highlights that I want to mention, right? Now, Hodgkin's, classic Hodgkin's, by the way. The type of cell the pathologist would recognize by looking at the bone marrow biopsy. There are a couple. There's what they call the popcorn type, and then the Reed-Steinberg type. And those are both given to you on this last page, and they're bold. Okay? So if you read through here, the tumor cell of lymphocytic, okay, or predominant, or the first one, LP there. LP, characteristic of what they call popcorn cells. So if you look at figure 2814 at the bottom of the page, there, you can pick out a cell that looks like a popcorn kernel, a popped popcorn. It's in kind of just right of center. Okay, it looks like an exploding popcorn type of cell. If you read the caption, nodular lymphocytic predominant, or LP, Hodgkin's lymphoma, has a large popcorn cell. What's that consist of? Multiple lobes in the nucleus, and very, 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 very delicate membrane, small, and some basicilla. So it just looks like the tumor cell that represents LP is popcorn. Okay? So if you remember that fact, you're in good shape. Now the other, Reed-Steinberg. The Reed-Steinberg cell is often described as the face of an owl, okay, with big eyes. And so if you look at figure 2815, illustration A, it's showing you classic Reed-Steinberg cells, okay? And often we see this in, as I said, classic types of Hodgkin's lymphoma. So there's a reddish type of nucleus on HD stain. HD is an eosine stain, i.e. red. So the nucleus is kind of reddish. Okay. The cytoplasm is kind of stretched and hollow, and that gives you the big owl eye appearance. And there's usually two nuclei with the clearings that are around each of those nuclei. And can you see how it could be called an owl type of cell? That's characteristic. Reed-Steinberg cells are characteristic. And if those are found, they know they're looking at a classic Hodgkin's lymphoma situation, given a lymph node, and the other characteristics involved. All right? Now, thirdly, the lacunar type cell. Okay? And if you read 2 in your book, in nodular, illustration, well, it's represented under low power, illustration B. There are C-shaped types of bands of fibrinous tissue. Okay. And if I mentioned in the table above that nodular sclerotic types of Hodgkin's do present with this fibrinous presentation. Okay. And so if you look at the lymph node biopsy, you guys can see the fibrinous bands that are kind of just forcing a nodular appearance of cells in the lymph node, right? So there's these, what they call the C-shaped bands of fibrinous material that encircle, or they don't encircle, but they kind of force a nodular appearance of the lymphocytic presentation of lymph nodes under the microscope. Okay? In addition, okay, the tumor cells are classified as lacunar, L-A-C-U-N-E-R, and that's the last illustration. Again, looking at these cells, you have a nuclear stained clear zone around each of those nuclear presentations. Lots and lots of clear cytoplasm. But two, inside the nuclei are kind of very pinpoint areas of intense blue, like polka dots of intense blue in the nuclear presentation of leukemia cells. Okay, that closes the chapter.